So I am really pleased to welcome our panel along with us. As you can see by the titles on the front page, we have got a huge amount of wisdom and experience in the room that's going to be shared with us today. So welcome to our panel. I would first like to start by acknowledging the traditional owners of the land and the waterways that we are all working and living in. I'm coming from the land of the Wurundjeri people of the Kulin Nation, and I pay my respects to all elders past, present, future and emerging, and also to any Aboriginal and Torres Strait Islanders that are with us today, and pay my greatest respects. So welcome to our conversation around supportive care today. And to kick off with, let's just do a little bit of housekeeping. We will be looking at the good things that are going on in supportive care. We know there is so much going on. We'll be looking at the things that could be improved, and we'll be looking at the potential as well. So the first half of today will be all about going through asking questions of all our panel, and our panel will be giving us their insights from their particular perspective. We've got a great range of perspectives around this topic today. And then in the second half, we will be having a question and answer sort of environment. So you will see, if you're not familiar with Zoom, that down underneath on the bottom of your screen, you will see there is a Q&A button. That Q&A button is there for you to post some questions in. And what happens with those questions is we have a great team behind the scenes, and they are going through the questions that are going to be posted, and they're going to bring some of them to the front of our thinking in the second half. And the panel is going to have a conversation around them. They will also be looking at what are the themes of the conversations, because we're assuming that we won't be able to get through them all, but they will be recorded so that we've got a hold of them and we can look at the themes and have that conversation. So I think if we're all ready to kick off, we may start the conversation around, first off, who is in the room. So we're actually going to do a poll. So I am going to launch a poll that asks where you are from. So if you are coming in to have a listen today, I've just launched a poll which hopefully has come up on your screen, which asks you what is your role or your work. And it's in the room today. It would be great for us to know who we're talking with. So, and I can see the results coming in, which is fantastic. Thank you to those people getting on there straight away and popping those on. We're halfway there. And pop in on other. Great. So we've got a great representation of people actually providing supportive services today, and also people that don't, or people who might be involved in actually accessing those supportive services. Fantastic. I'm going to give you a couple more minutes just to see what's your role or your work. Almost there. Okay, I'm going to end that poll now, and I'm going to share those results. There we can see who is on screen. We have got just a great range of nurses. We've got allied health, we have Department of Health, we've got consumers, psychological safe services, researchers, administration and management, and other. And 69% of the people on the call provide supportive services, and 31 don't or are involved perhaps in accessing them or are very interested in the information that we're looking at today. So thank you for that. That's great for us to sort of know who is online, and also useful for us to all know it as well that are on the panel. So let's kick off, and we're going to kick off just looking at generally supportive care, which we know addresses a wide range of needs across the continuum of the cancer journey and is a core component of cancer care. So it's one of the biggest priority areas for the Integrated Cancer Services, ICS, and the major platform for implementing the cancer reform agenda in Victoria. We know that data shows that most public hospitals don't reach supportive care targets set by the Department of Health. And today we want to have a good conversation around that. It's not all bad. There are some great supportive care initiatives happening, and many in our audience today would be aware of these. Some services do supportive care really well, but in others there are gaps and challenges, which means there's opportunity and potential to do better. And that is something that we'll discuss later in the program. With me today online are our panel members. You'll meet them shortly. Their collective knowledge and experience will provide insight into what works well in the supportive care space and where are those gaps and challenges mentioned earlier. We will not have all the answers today, but let's be honest about what's not working well and put it out there for discussion. So let's dive right into the good, the bad, and the potential. Welcome, panel. And I'm going to kick off with what I'm told today is one of the biggest challenges, and that is to screen or not to screen. And equally, what is perception and what is reality about screening and referring? So in some settings, there is still a perception from health services and clinicians that all supportive care can or should be provided via the health service. And there's a reluctance to offer a supporting care screen because of the perception that there's nowhere to refer if an unmet need is identified. So Ellen Hayward, I'd love to start with you. You're currently Nursing Services Manager for the Haematology Oncology Centre at Alfred Health. I'd like to ask you firstly, what is screening for those of us who might not know exactly, and who is responsible or who should be to screen patients for their supportive care needs?
Thanks, Tracy. So what is screening? So our supportive care screening tool looks at all the fundamental areas within a patient in terms of whether they're requiring financial support, child support, things going around maybe for them potentially in work, how they're coping emotionally, so looking at the distress thermometer. We also incorporate nutrition screening in that as well. So it really gives us a bit of a snapshot around those particular areas that a patient may be struggling with on top of a cancer diagnosis, and then flags to us potentially who we could refer the patient on to. So it really is great in terms of opening up a conversation and a dialogue, doing a bit of a deeper dive into areas. And it could be things that you're able to solve then and there on the spot by providing, it could be some verbal information or some written information from Cancer Council or some of the other supportive care networks. Who is responsible? Great question. To me, everybody is responsible for supportive care screening, but I think the default position for a lot of these initiatives is nursing, and I think because nursing is by far the most constant. But for me, there's nothing stopping a doctor within a consult performing supportive care screening, or an allied health member that might be involved in the patient's care, particularly at time points where we see a change in the patient's condition. So, of course, up front, I think predominantly that could be done in the medical setting, or when a patient comes in for their treatment, could be done there by the nursing staff. There's also thoughts around perhaps this could be sent out to the patient before they even hit the centre. So when they come along prepared, and it starts that conversation. So I really do believe it's everyone's responsibility. I believe it then demonstrates to the patient that we all care about their supportive care needs, and that we're all willing to listen and help in whichever way we can.
Yeah. So in the 2020 Cancer Services Performance Indicator audit, there was only 37% of patients in the southern Melbourne region with documented evidence of a supportive care screen in the medical record. Why do you think this rate is so low?
I think when anyone mentions 2020, the immediate response is COVID.
Yeah.
And I think probably for a couple of reasons. So if I think about the ambulatory setting, we obviously reduced the number of patients that were presenting face-to-face. Lots of appointments were converted to telehealth, or patients were switched over to HIF modalities. And I know I worked across 2 health services in 2020. We didn't have an electronic solution for the supportive care screening. So it was a paper form that had to be handed out to the patient. So obviously less presentations, there's less opportunity for the supportive care screen to take place. Or if it was being taken place in, say, a telehealth format, there maybe wasn't the appropriate documentation to support that. Not to say that the conversations weren't happening or the referrals weren't being made, but it just wasn't being documented. If I think within an inpatient setting, a lot of, in particular, trained staff were moved into critical care areas, so ICU and EDs, to help support COVID surge, which meant that you lost the people that were trained in supportive care screening or understood the time points and when that needed to happen. And then wards had an influx of very junior staff who wouldn't have been trained in this particular assessment of the patient. And I think for the inpatient staff, it was really just around the fundamentals of, providing the day-to-day ADLs, and not so much as what, in some areas is seen as an additional task. And I think supportive care screening, I know particularly at the Alfred, we really only started to introduce it in 2020, so it wasn't ingrained in practice. And that would probably be another reason for those low rates.
Yeah, that's really interesting overview. And I think it's what we're all facing as a society, isn't it? Is, as we come out of that crisis response, how are we actually refilling those gaps or putting in systems that actually support people to be able to step into using the things that really make a long-term difference on health outcomes? So great. Thanks so much, Ellen. Associate Professor Andrew Hayton, you're the Joint Clinical Director at the Southern Metropolitan Integrated Cancer Service and a medical oncologist at both the Alfred and Wonthaggi hospitals. From your perspective, do you feel that supportive care is prioritised by administrators?
No, in a word, I'd say no. I think that supportive care is certainly not a KPI for administrators. They're interested in length of stay, averages, WEIS funding, elective surgery waiting lists, how many patients spend more than 6 hours in emergency departments, those kind of things. And I think they're probably judged more on those KPIs than certainly supportive care. So I certainly don't think it's high on their list of priorities. The other thing is, when you kind of try and plead for increased support for supportive care services, the standard response is to show us the business case. Well, whenever you want to change something, you've got to show a business case, and that business case is often around, well, how is this going to be either cost neutral or making a profit for the organisation? And so if we invest X number of dollars here, what's the return, and how are we going to justify that, at the end of the day from the bottom line? And the reality is that supportive care services don't save the hospital money, or they don't make the hospital money. It doesn't reduce the number of admissions to the hospital, or I think that the improvements that we see with supportive care are measured in patient satisfaction, and that's not something that you can easily build into a business case.
So if it's not prioritised, KPIs don't match to it, what are the implications for patients? And also clinicians, but first off, patients.
Yeah, the obvious implication is that there isn't enough of these supportive care services within the hospital, and so patients often will miss out. Simply, if the services are not available here in the public system, and they need the services, they'll need to be referred elsewhere. And referring elsewhere, we don't necessarily like to have patients being cared for outside of the institution, because I suppose we don't really have a good understanding as to whether the person we're referring to outside actually, is an expert in this area, or has the right training. Have they, Are they particularly subspecialised in the management of patients with cancer? From a clinician point of view, I think that the problem is that it's going to increase the time that it takes for us to deal with this. Referring outside the hospital is always more time consuming than inside the hospital. Having to find where to refer, how to do it, all those kind of things. And it may well be that, because it's all too difficult, it just doesn't get done. And clinicians certainly don't have the time or the expertise and training to kind of take on the role of all of the allied health professionals that are required for adequate supportive care.
Okay, thanks, Andrew. So a real issue around the systemness, isn't there? The system connection, but also the trust that also sits there as well, and the big why. How do we make it really obvious what the big why is around supportive care being in touch? So Catherine, I'm going to come to you as the head of Cancer Information and Support Services. Thanks, Andrew, for your input there. And Catherine, you're at Cancer Council Victoria, and you are also an oncology nurse by background. Irrespective of whether there's a perceived lack of pathways available to patients, it doesn't mean that a patient's unmet needs disappear, though, does it? What's your perspective around the fact that there are patients with unmet needs around their care journey?
Yeah, Tracy, I think the most difficult thing that we do here, we have our nurse-led information and support line here. And I think constantly in the time that I've been here, we always hear that people didn't know what we provided, didn't know what support was available, wish they'd known about us sooner. And a lot of the time, the questions and concerns that people have, for us anyway, don't always relate to the implications of their treatment or their side effects. It's often about the emotional impact, the financial and practical impacts, the impacts on the people around them. And understandably, that isn't always something that an acute health service can focus on or has the resources to focus on. So for us, it's really important for us as a not-for-profit and as an organisation in the community to always be promoting the services that we provide and to really help people to understand the benefit of what those services can provide. They're free of charge to patients. They're, to the best of our abilities, easy to access and are available statewide. So really, we've got that job to really improve that understanding. And speaking to Andrew's point, absolutely, we understand that there is a reluctance to refer outside of a health service where you don't have that understanding or control about what is available. But speaking from a Cancer Council perspective, our nurses on the information and support line are all experienced cancer nurses with a minimum of 5 years experience, and 3/4 of that 14-person team are still working clinically across a variety of settings. So they have both current and previous experience of what it's like across public and private settings, and now across rural and metropolitan settings as well. So they have as much knowledge as you can possibly have outside of the actual acute health service that a person is being referred from. So for me, I think it really is about that idea that while we absolutely understand there's work to do to improve and streamline pathways and to improve that awareness and understanding for people to refer themselves, there's also a real role for health professionals to look at how they refer quickly and easily to other services that can support to address those needs. Because as we mentioned, they don't disappear just because we don't have the time or the resources. And those needs change over time. They can change hour to hour, day to day. So those services need to be front of people's mind and able to be signposted to by people that they trust at their health service so that they're accessed at the right time.
Yeah, great. And, you mentioned that, people need different types of care. And I'm presuming that, as someone moves away from the acute, the contact with the health service lessens over time. So how important is it for patients and their families to know about community care, community-based care, and how easy is it for people to find it? I know you mentioned it's a real focus for you, but in general for services, where is the link that helps people understand where that community-based care is?
Yeah, I mean, just to pick up the first point around the idea that those needs change over time, and as people transition away from health services or where their treatment contact changes, it's really important that people know where to go, because they're not always familiar with the fact that they can contact their GP in between appointments. They're not always sure about whether they can even contact their treating centre. There's this real perception that we hear about around their treating team, nurses, their clinicians, allied health being so busy that they don't want to burden their team with questions not related to their treatment. So we try and take, I guess, a multi-pronged approach here at Cancer Council. We know that our education and information resources are readily available in most settings, and that's a really great start. But people often won't make the link to the fact that there's an information and support line available to them, or the fact that there are support services that can be accessed, even though they're mentioned all the way through those resources. The uptake of those services can be quite low without that directed and that signposting from a health professional that they trust. So we've created an online referral form for health professionals to be able to use across any profession, any allied health, any clinicians, anyone that is in contact with a person and identifies a need can put in that referral, so that one of our team can then proactively contact that person to address those needs and put ongoing support in place. And what we found is that people who are referred to us via that form, via a health professional, are then far more likely to pick up the phone or make contact with us themselves proactively moving forward. Once they've had that first contact and they know who we are and what we can support with, and the fact that we will always signpost them back to their health service when needed, they're much more likely to then make ongoing contact with us when those needs change over time. So that's really what we're trying to focus on. And I think it's important for people to build that self-management and that awareness, but I think there still is always going to be a need for health professionals who are involved in their care to signpost across. And I think one of the challenges we find is that even where services are completing screening, it's that action piece that actually actions a referral after that screen has been completed that we still need to work on.
Oh, great. Thanks, Catherine. And from my perspective as a user of health systems and also around knowing what gets people's buy-in is probably the stories that are being told at the same time as that referral form being given of people experiencing those services rather than words written. When we because we're talking about the heart work, aren't we? We're talking about the emotional connection to our ongoing care. And so the referring person giving the referral form has got a lot of insight into great stories and journeys, haven't they? And it brings it to life for people. Thank you very much, Catherine, for that insight. And I'd like to bring Kirby in at this point. So Kirby, you're currently Project Director of Home and Ambulatory Care at Cabrini Health on secondment from your substantive role as Chief of Allied Health and Ambulatory Services. You've recently completed a major project which has been funded by SMICS, implementing an electronic supportive care screening tool, which we're going to look at later in the program. You're going to give us a bit of an overview of it, which is fantastic. From your perspective, what's the biggest challenge in ensuring patients receive a supportive care screen?
Yeah, it's a great question. So initially, our biggest issue was not actually the screen itself, but it was, as Catherine just highlighted and others have, something happening with it. And that really formed the basis of our problem. The challenge now, I think, is in the midst of everything else going on, patients then prioritising completing that and following up. And we've certainly learned recently patients who have, identified distress multiple times on the tools, who have been provided resources, but aren't at that point in their mental capacity and mental load to change, address. And this is where we see it a lot with patients going through treatment. They can take things on at a certain point in time and not at others. When their bucket's overflowing, where they're still just coming to terms with a diagnosis or coming to terms with a new treatment plan, or I'm now going to have 3 weekly infusions for the rest of my life. Yeah. Sometimes that's not the time for supportive care. So that's probably the biggest challenge we're facing at the moment, is the timing piece. And getting that right to not only just impose our healthcare professional opinion onto our patients to say, you've got this problem that we want to help you fix for you, that kind of mentality, but meeting them halfway in terms of their preparedness for that.
Yeah, great. And I'm going to come back to you in a question on that in a moment, Kirby, but I might just jump to Viv. You have had your own cancer journey. And I imagine that the point of diagnosis or beginning of treatment, incredibly distressing and overwhelming time for people. And they might not have just the headspace to consider anything more than treatment, as Kirby was just referring to. Can you recall if you were offered supportive care screening? And if you were, was the timing appropriate for you?
Thanks, Tracy. You are on point there. It's a very difficult time at point of diagnosis to take in any information except the one that oncologist, for me, it was breast cancer. It's sitting in front of you saying, you know, it is cancerous and this, you know, we got to get you into theater right now. And, you know, for a lot of us patients, our mind spins to our families. I have two teenagers now. They were in primary school back then. And, you know, my mind spun straight to, are they going to be okay? Are they going to cope with this? And the supportive care pre-screening, I'm trying to think back, my memory's not so good these days, but I'm trying to think back to 2018 when it all happened. I do remember being asked the questions, but more at the end of my whole year of cancer treatment rather than at the beginning. So I think timing of when it's asked is very important because, you know, we sit in that space of treatment, the acute treatment where the hospital is all around us. And then we go into the chronic, you know, when we step out of the hospital system. And when does the pre-screening happen? When is the right time that the patient and their families are ready to hear it? You know, because it's very hard, like, you know, I think you all talked about, you know, we look at the diet and the food, but at that point of diagnosis, when, you know, people turn around and say, well, are you eating healthily? I actually took it as, are you telling me I'm not eating healthily? Are you saying that I haven't looked after myself? That's why cancer has hit me. So, you know, I took it very much as, don't blame me. I didn't do anything wrong here, because we're going through that guilt feeling of what did I do to deserve this? And we know cancer doesn't discriminate, you know, but at that point when you are told you have a cancer diagnosis, your mind spins into, what did I do to deserve this? Yeah. And so when a clinician comes into that space and go, you know, we're going to run a pre-screening tool, we're going to talk about your diet and your emotional space and your psychological stuff. Not the right time, because we go, are you telling me I've done it wrong here? Yes. So, you know, I think something to think about, you know.
Great perspective and insight that you've given us there, Viv. As you progress through your active treatment into a survivorship space, would you have welcomed, or did you might have received it, but being offered additional screening, you know, and are there some milestones through screening that could be routinely offered, and, you know, over time that comes up for you?
Absolutely. I think where it really made sense was when I was going through chemotherapy at Monash. And that's where you form that trust relationship with the nurses that, you know, stick everything in you and put cold caps on, and they come and give you hot beef soup, and they put, you know, warm heat packs on you because you're freezing like crazy. They were the ones who then came into that space. And that's when the conversation really happened, because we trust them. We have that relationship. And that's when they go, you know, tell me a little bit about what's happening at home. Are you okay? Is your husband okay? Are your family, are your kids okay? And that's where they can have that narration around, you know, do we need to get her more supportive care around this? And we tell our stories because we trust them. It's not someone who we see once every 6 months who's asking us this question. So I think that trust factor, that relationship build-up is really important. And I did receive that, you know, when it started during my treatment. And we have, I remember volunteers coming in as well and sitting with me and sharing that space, and they would check in. And I think, you know, use them to do some of this screening. It doesn't, as we said just now, it doesn't always have to be the nurse. But, you know, you've got volunteers, for me, it was the breast care nurse that I formed a good relationship with as well. And they checked in with me. So along the journey, absolutely, because that's where you're, you know, as a patient, I start to think, okay, I've got care around me. People care for me. They try to look out for me. So how, you know, what can I tell them about what I need so that they can put the right services in place for me and my family?
Yeah, great. Thanks, Viv. Again, just such an important perspective you bring to us on the panel today. Thanks so much for that. Kirby, I'm going to pop back to you and just ask you, when patients do complete the supportive care screen, do they always go on to receive the referrals or the services, the supportive care services, in an appropriate or timely manner? You know, does that happen, or is it, as you know, Viv sort of mentioned, that more informal? Is it sometimes enough just to have that conversation and get additional information sufficient rather than going into the complexity of a tool?
Yeah, great question, and thanks, Viv. I think your perspective on it is really, really valuable. Look, to answer the question, Tracy, it's both. It's a mixed bag. I think supportive care, given the breadth of the services that sort of encapsulates, is going to come about through several mechanisms. The informal, what I consider to be the informal ones, as Viv described, the point in time ones are great, and hopefully they lead to timely referrals and follow-up. The screening tools, I think the value they add is distinguishing change, prompting people to actually think about additional things beyond what their medical treatment, those sorts of things. And the timeliness of response to the outcomes of that, I dare say, is service dependent, day dependent, month dependent. I'm obviously coming from a private health perspective, and we've set up systems and processes to try and provide a really timely response to any issues identified. And the funding mechanisms for us are a bit different to what we see in the public. But again, there still needs to be that patient sort of acceptance and willingness that this is something that I need to do. And if it is private, sometimes they're out of pocket. So it's that the value attribution to that. For things like dietetics, for exercise physiology, we're seeing a pretty good, and psychology, a good recognition. But when we move beyond some of those into things that, from our perspective, have huge value, social work, and some of the financial conversations, affairs, all those sorts of things, there's not a financial value attribution to that, and they're the services that we see the lag, and it tends to wait until there's a crisis point before that, and that's really, in my mind, I think, rehab, those sorts of services, that's where we can manipulate funding a bit to provide some of those evidence-based clinical services. It's the softer ones, which is the biggest gap in my mind, but they're also probably the most important.
Yeah, absolutely. Thanks, Kirby. And I think that leads us really well, I think, to Vicky McLeod. You're a nurse practitioner and you work with the oncology team at Monash Health and run a supportive care clinic where patients are able to be reviewed between doctors' visits for assessment of symptoms and to address supportive care needs. We often think, as Kirby just mentioned, of supportive care as psychological, emotional support. But, he's also mentioned some really good practical things around dietetics, etc. From your perspective, what other kinds of supportive care services do patients benefit most from, or could they benefit most from?
I guess, Tracy, that's where the supportive care screen really helps you identify what the individual needs or what the caregivers might need. And so any domain, that patient may have any domain of needs. So it might be physical things, they may have pain, they may have nausea, they may have weight loss. From a social perspective, they may have poor social supports, they might need help, practical help with their childcare or housing. And that's where actually doing the screen allows you to identify what's the most important need for the patient, and then to try to tailor the services to that patient. And it is, even though I might think that the nutrition is really important, that getting the child picked up from childcare might be the most important thing for that patient. So it's dealing with each individual need with the patient's perspective in mind. So there might be a range of services that I might refer to, from dietetics, exercise physiology, physio, my age care for domestic assistance, psychology, financial counselling. Big plug to the Cancer Council and their referral form. It makes it so much easier for clinicians to do that referral and know that a lot of these things will be followed up. So if they don't have an acute need for me to deal with at the time, that referral form allows me to hand on to somebody else to follow up some of these important supportive care services.
Can I ask, do you find, are those services readily available? And, you know, are there barriers for patients accessing them from your perspective?
There are many services out there, and there are many barriers. Some services are very easy to access, particularly if they're coming into a day chemotherapy unit. However, for patients that may not be coming to a day chemotherapy unit, having oral therapies, it's much more difficult to access supportive care services. Patients, you know, some of the areas that I have difficulty accessing assistance are things like continence nurse assessments. You know, there's a 2 to 6 month wait for a non-urgent assessment. Speech therapy in the community is very difficult to access through community health hubs. However, there's been a lot of really good advancements in the last few years. There's now, not only have we got the Cancer Council team, we've got neuroendocrine tumour nurses that have dietetics through their service, through the bowel cancer nurses or bowel cancer association. We've got a dietitian through there. So even if the patients are coming through the day chemotherapy unit, there are other ways of accessing these services. Yeah. But it takes time to find those services and to link the patients with the services.
Yeah. And, you know, the access to those services can also sometimes, as you mentioned, there's sometimes the wait times, regional perspectives as well, rural perspectives, and even getting access to that supportive care tool in the first place. So I wonder if this is really an equity issue that we're looking at here. You know, why is it that some patients have access to screening supportive care services and others don't? So thanks so much, Vicky, for that perspective. And I'd really like to just unpack a little bit around this this equity of access to supportive care and looking at those barriers. Are supportive care services more accessible for inpatients versus outpatients, as Vicky already indicated, or for patients receiving active treatment versus post-treatment? If I was a medical patient rather than a surgical patient, would I get different access to those supportive care services? If I have breast cancer opposed to brain cancer, will I have better access to supportive care? So let's explore that a bit. And Tennille, I'd like to go to you. You work at the Peter MacCallum Cancer Centre, and you also developed and now coordinate the supportive care and palliative care subject for the Masters of Cancer Sciences offered at the University of Melbourne. So Tennille, we believe that the vast majority of supportive care screens are undertaken by nursing staff, particularly when there's a nurse coordinator available. What happens to those patients who don't have access to a nurse coordinator? Is there equitable access to patients across tumour streams and across health services? What's your perspective on that?
I want to go back to something that Andrew said earlier, which was, in one word, no. But that's the short answer. And first of all, I think it's really important that when we talk about equity of care in supportive care for cancer patients, and that's any cancer patient, that we distinguish between equality and equity. Not every patient is going to need all of these things that we've all been discussing today. Psychological care, which I know we'll discuss a little bit later, you know, speech pathology, occupational therapy, financial support. Every single person will have a nuance to what their supportive care needs are. And I think that is the importance of the screening. But exactly what you said and what Alan said earlier is that supportive care, identifying and addressing supportive care needs really does come down to resourcing. And we know that it falls to the nurses. So depending on what hospital you are diagnosed at, depending on what cancer type you're diagnosed with, and then, as you were saying, what treatment you're having. So if you're admitted to a hospital and you are under, you know, you're going for surgery before you go in to have chemotherapy or radiotherapy later, will really depend on whether you have that immediate access to a cancer nurse specialist, a specialist cancer nurse. there have been some real big improvements, and I know we're talking about the good, the bad, and the potential. There's been some really great improvements around Victoria with the introduction of the urgent symptom review clinics, so the SMICS clinics. And so they're usually run by specialist cancer nurses. But again, coming back to this idea that a lot of patients will go or will present to the SMICS with their physical symptoms and side effects. So, and again, leaving behind the emotional distress, leaving behind the practical issues, the financial burden that they're supporting. And so we need to try and work out a way that patients have an opportunity, or they have a space where they can report their unmet supportive care needs. Yes, it's great. These places, you know, the health services, whether it's regional or metropolitan, having access to a cancer nurse specialist is, you know, the gold standard. It's what we want for all patients. But that's not reality, Tracy. We don't live in reality in that space. Some patients will have much better access to a cancer nurse specialist than others, and that's not equitable. If we think about somebody that lives really rurally, they're not just their access to having their supportive care needs identified, but having access to the services that are required to support those needs, they're just not there. So I think we come full circle round to, again, what Alan was saying. It should be supportive care. Identifying supportive care needs should be everybody's responsibility. We should all be comfortable to have a conversation with the patient about what it is that they need to be able to get through their treatment, to be able to attend their treatment, to be able to support them through their treatment at any point of their diagnosis, their treatment, and particularly after their treatment, when they start to go into that, what we now see as living well with cancer space. How do we support these people to live well with their cancer? Treatments are prolonging life. And so we have more and more people that are in the community living with their cancer. They're not cured from it. They're not in remission from it, but they are continually living with it. And so we need to think about how do we do things differently. And I'm really excited to hear about Kirby's study a little bit later, because I'm currently also involved doing my PhD as part of a supportive care clinical trial that looks at actually modes of delivery of patients identifying and reporting their own supportive care needs. So looking at patient reported outcomes. So again, I think it's not equality. We don't want equality. We can't get equality, but at the moment we don't even have equity. And that's the most important part. And it does come down to resourcing, and which comes down to funding. But that means that if there's no more money in the bucket, which we know there's not, then how do we do things differently to bridge that gap in equity of care?
Yeah, great. And also build that business case for shifts around that is so important, isn't it? Which is, can I just ask a quick one to you of why is it so, what's the important clinical outcomes when people have their supportive care needs identified? Because that seems to be the crux of the getting the funding is, you know, how do we make it really clear the which we know it shouldn't be like that, but the reality of what was raised by Andrew very first up around measurement and funding. What is the outcome clinically around supportive care?
Look, I think when we go back 20 years in the field, in the realm of supportive care, it was very much around supportive care being this fluffy, nice to have, right? It's an added extra to their clinical treatment. We have come a long way from that, but I still think there is a huge way to go in bridging that gap, that supportive care isn't the nice to have, it is the need to have. People have the right to have their supportive care needs. Clinically, we look at this idea. I know Andrew was saying that it's really hard to build that business case because supportive care provision doesn't bring money into the hospital. But what it does do is lots of evidence is now coming out to show the health economics around supportive care. So not just to the health service, but maybe even more importantly to the patient and their family. So, having early intervention of supportive care reduces the financial burden on these patients. It reduces the emotional burden on these patients. So we need to look at it from not just a cost spending from a health service perspective, but also looking at it from a reduction of cost emotionally and financially and practically for patients. Yeah. There's lots of research around supportive care that we now know shows that early intervention and good supportive care improves quality of life for cancer patients. So it means they have a better life. But what it's also now starting to show is that what it does is when we have good supportive care, which means we think about the whole person. So if I do a little bit of a case scenario for you, Tracy, if I've got a farmer who lives in rural Victoria, he's got 1,000 head of cattle and he has a cancer diagnosis, that means that he's diagnosed in his local area, local cancer service, which still may be an hour and a half away from home, from his farm, his working farm. If no one addresses his supportive care needs about how isolated is he, what supports does he have around family, friends, colleagues that he can refer to support here, we won't be able to get him through his treatment. At some point he will say, actually, I have to make a living and I can't leave the farm for every day, Monday to Friday, for 7 weeks. And so I'm going to maybe consider not having treatment. And so if we're reducing the ability of people to complete their entire treatment regime, then we're impacting their opportunity to survive the cancer, to have a long-term remission or a long-term living with cancer, which means we're impacting their length of survival. And there's lots and lots of research being done around that at the moment. So clinically it's about getting them through their treatment and making sure that we don't just think about it from a health service cost perspective.
I reckon, and I love the why that you've framed for us there. What it's such an important thing that we look at. There's a big why that we're doing around this, and how do we actually elevate up our particular areas that we might look at it from a whole of community view and right down to the patient sitting in the centre. Thanks so much, Tennille, for that great insight. And I'd love to go to Debbie, who is, again, someone who has experienced a cancer journey. And Debbie, in the space of 1 month, you went from a cold and flu checkup to finding you had cancer in 2 parts of your body, and quite aggressive cancer too. And it's so wonderful to say that you are now cancer-free and have been for some time now. And from the information you provided us, one of the things that really stood out for me was the amazing support from your family and friends, but also just how strong an advocate you have been for yourself in terms of making your way through the journey. And I'd really love to get some insight from you around supportive care for your family and friends. So did they get access to supportive care? Were they offered it? Were they given resources or referrals to help them through their journey? What's your perspective on that, your experience?
I don't think any of them were offered that, or it was not an option given to me. And I know that my mum keeps saying to me, one of the things that would have helped her an awful lot was to have had a counsellor to talk to, because in some ways, I'm glad I'm surviving cancer. I didn't want cancer, but I would rather that it was me that had cancer. I wouldn't have liked to have been my mum or my sister who was watching me go through cancer and go through the treatment and see how I was looking and how I was feeling and all of that sort of stuff. So Mum never said to me, I'd like to talk to somebody until after I'd been through all the treatment. But I still think that she does say, has said on a few occasions that she'd like to talk to people.
Yeah.
And I don't know whether she'd like to talk to somebody now about it or not. And perhaps I might explore that a little bit further and make use of the Cancer Council people, which I perhaps I've not really been, I'm not sure exactly what they offer. So
do you think it would have been useful for them, say for your mum, to actually go through a tool or a bit of an addition to the tool that you might have gone through?
I think it probably would have been beneficial for her, yes. It would have been nice to have had maybe a similar sort of screening tool sent to family and friends, or, you know, here's a piece of paper, give it to your mum or give it to your friends if you think any of them need it, because there is support around that might be able to help.
Yeah, great.
Right.
Yeah, thanks, Debbie. I think I love that you're going, yep, I'm moving into action straight away after this, which is fantastic. And Andrew Hayden, I might come back to you on this point, if that's okay. We've just heard, you know, the stress burden on families and carers is enormous, you know, and again, it probably varies from experience to experience, and even more so for the patient. Of course, but will all patients need a referral for psychological support if we look at psychological support?
So, I don't think all patients need a referral to see a psychologist, but I think that all patients should be screened, you know, and then obviously those that are identified as needing it, you know, should be referred. But I think that also the majority of patients would actually benefit from at least touching base with some kind of psychological support, particularly early on around the time of diagnosis, and that you know, maybe one or two meetings might in fact prevent the need for many meetings later on down the track. You know, it might be preventative in some degree.
Yeah, and I think back to Viv and your thoughts about where you were at that diagnosis time of being all over the place. That perhaps actually that conversation or those conversations might have been really useful in that environment. Would you? I see you nodding there. So.
Yeah, absolutely. You know, and it's not just me. I think it's for my partner, you know, for the kids, for the family, all friends, because, you know, we also have that lens of sometimes for a patient, the family isn't the best choice of supporting them in this cancer journey. So, you know, I think it's how do we do that pre-screening in a way that not only do we identify what is needed, but the who should be in the door, and what. To Tennille's point, right? What services do they actually need, when and where? Yeah. So I think, you know, absolutely, if there was that tool at that point, I think it's important. I remember, I just wanted to add on to what Debbie was saying. And I remember when I was going through it, you know, the breast care nurse was beautiful in offering us some resources around for our children. From the Cancer Council Victoria, there was this little wonderful booklet where, you know, it was telling a story of cancer, but in you know, young ones' minds and the language to use. So, you know, I think it's how do you bring that educational piece to the medical world, as well as, you know, there are resources out there. These are some of the Cancer Council Victoria. There is the community supports, the allied health, even the pharmacists of the world, because my pharmacist down the road now has gotten to know me so well, because I go there every month to go and pick up all my different medicines. I'm 4 years into it, but I'm still on a of medicine. So, you know, how do we tap into all of that system so that helps with, you know, who do you refer out to? Are there people out there?
Yeah, great. Yeah, thanks, Viv. And again, those connections, those links and that knowledge, connection, relationships and knowledge just comes up again when we hear from you every time. Andrew, in terms of the psycho-oncology services, particularly for patients in public hospitals, how accessible are they?
Well, it's better than it was a few years ago, but it's still very much, I think, an under-resourced service. And really what that means is that we almost have to triage that only those with the greatest degree of psychiatric or psychological distress are the ones that get, referred, which means that, a large number of patients with low levels of moderate amounts of distress don't get referred, just because of the practical realities of, of trying to deal with, a hospital with thousands of cancer patients and one psychologist that works 1.5 days a week, and it also means that they generally won't get ongoing support. It'll be a one-off meeting, and they don't have the ability to be seeing patients regularly and following them up and offering ongoing support. So it's very difficult and clearly very under-resourced, and because of that, people are, by necessity, are having to be referred out. And I don't think you need me to tell you that in recent times the need for psychological support amongst the community has gone through the roof, and so I suspect that being able to access these services outside of the public hospitals isn't easy, and the waiting times would be quite unacceptable.
Yeah, and Catherine, I think you might be going to add something in there. We're such a stressed system around mental health needs for mental wellness at the moment, aren't we? What your perspective on that?
I think Tanil and I are both chomping at the bit to answer that one. So I'll just quickly add my little piece first. Yep. And I mean, it's exactly right. There was a question that's come through the chat earlier about what capacity does Cancer Council have to meet the psychological referral needs of people coming through. And look, the reality is that the services that we have available, we now have two arms to the services that we can provide to patients who can't otherwise access support. We have access to be able to provide people referral to a phone based psycho-oncology service where it's offered in partnership with Cancer Council Queensland, and those referrals are to psychologists who only deal with cancer patients and their families. So we have that access available, but we also stood up during COVID a nurse-led counselling service. So if you think of our Cancer Council nurses on 13, 11, 20 as the first level of intervention for people who have supportive care needs or need to talk about their emotional concerns, we then have the ability to step them to nurse counselling if they have that lower level, more transient distress, like adjustment to diagnosis, fatigue, sleep problems, those kind of issues. And then we can step them up further to psycho-oncology through Cancer Council Queensland if they need. We will always make sure that people are referred and able to access local services or community-based services or anything that is available through the acute setting. But I'd be lying if I said that our services weren't at capacity either. We have all known through COVID that the mental health system was already struggling prior to COVID. It's become even worse since COVID. So that's why we stood up our nurse-led counselling service throughout, and that's a capacity that we're aiming to build to meet that need in the middle for people. But we also make use of services like Cancer Mind Care, which is an online platform that was developed through the Integrated Cancer Services, and I think with Peter Mack, if I'm remembering correctly. And it's a really important intervention to be able to assist people while they're waiting for those appointments. And our 13, 11, 20 nurses also implement increased follow-up calls to people. So if we know that there's a 5 to 6 week wait for an appointment, then we'll step up that ability to call out to people in the interim to make sure that they are receiving some support. And that speaks to Andrew's point around, we have that capacity through 13, 11, 20 to make that ongoing connection with people or their family members, so that if they are waiting for those acute services, they're not left completely on their own while they're waiting.
Yeah, great. Thanks, Catherine. Tenille, I'll pop to you. Just a quick one, if that's okay, because we've got a few people just moving into primary and community care, so that we want to hear from. But I'm sure you'll have something really useful to add.
I think it will lead perfectly into where you're heading, Tracy. And I think from what Andrew and Catherine have just said, I was going to talk about the fact that it comes back to that equity again. Not everyone's going to need a psycho-oncologist, but there is that meeting in between of counselling. And I think it's really important to bring in our primary care physicians here, because sending a patient to their GP, talking about a mental health care plan that can help them access counselling identifying if they need a psycho-oncologist, but then also making sure that we don't dismiss those that need that further care. So it comes back to that equity of care, but the primary health care is really important here.
Yeah, great. Yeah, let's have a bit of a look at that. I'll go over to our general practitioner on the panel. So Dr. Inez Rio, the majority of people have a GP that they see regularly. What's the role of GPs? And it's almost a misnomer that people do see a regular GP, isn't it? It'd be interesting to. I know there are statistics on that, and we've got a whole lot of vulnerable people who actually do not see a regular GP, which can be problematic in itself. But what's the role for GPs in identifying unmet need?
I'm going to build on really something that Catherine and Viv talked about, which is the importance of a trusting relationship. And the reality is that about 90% of people have GPs, and the average Australian sees a GP 6 times a year. If you've got a chronic disease, that's increased by another 30%. So the average person with a chronic disease, and perhaps you put people with a cancer diagnosis in that area, would see their general practitioner 9 times a year at least. Now, you're in a situation as a GP where you've often actually been part of that journey right from the beginning. You've identified the mark on the arm that's become the melanoma. In Debbie's case, the person that's been coming in with recurrent colds, you've done a CT scan, found a mass. The bowel cancer screening that you've agitated somebody to finally go to that comes back as positive, the lump in the breast. You've been there right from the beginning, and you usually know the person well. And so when the person walks in the door with the lump that you then get the core biopsy and find that's a malignancy, and you know that woman had her own mother die when she was, 50 and the woman was pregnant, it brings a lot of story to that relationship right from the beginning. You then as a GP actually then refer off to the hospital, and often during that acute treatment phase they get a little bit lost. Not necessarily, but they often do get a little bit lost in that often sort of 3 to 9 month phase. But that's a peg in their life, and you do still see them in that phase. They're often coming in trying to negotiate work. How am I going to talk to my child about this? My husband, who's got a gambling problem, has actually been exacerbated. So they're coming in and you're dealing with many issues at the time. I'm having problems with my sex life. What do I do with my medication? They're things that are about them and their story and their life, and you're dealing with these all the time with them and with their family.
Can I ask Inez around that? For GPs in general to be able to successfully do that supportive care role, what needs to be in place that you think might not be in place currently?
I think that there are lots of things that are in place that need to be recognised. And I think sometimes the broader and sometimes the public health sector don't realise that. They don't actually realise how often people have a relationship with their GP or how GPs know them, so that when you walk in the door, you don't start the conversation again, you build the conversation, you have a broader system of their life and their issues. I certainly think that the introduction, hopefully next year, of voluntary patient enrolment, which will actually strengthen the relationship, hopefully, between the general practice and the person, and really make that accountability both ways, actually strengthen, will be a positive thing from a health system point of view, but from a health delivery and accountability point of view. And I think it will also provide the mechanism to actually improve the funding models back to general practice to enable more of a multidisciplinary team. Yeah. Almost all GPs have, I've got 3 practice nurses with me. I have, dietitians, I have an OT, I have a speech pathologist on site. We work as a multidisciplinary team. And again, I think that sometimes public health sectors don't understand that. But even if they don't work in your room, you have those mechanisms and that network outside of your room, and you're dealing with it all the time, be it with a person with cancer or a person without cancer. And I think that the other thing that's really important that a few people have noticed is that every person's needs individual and every person's needs changes with time. Yeah. And we need to be actually responsive and listening and deeply listening to that, be that through that sort of GPs often do it through an ad hoc relationship base, but I think the strength of having formalised screening tools to pick up the things that you hadn't thought of or that somebody is not comfortable raising or they didn't even realise themselves. But building on our existing networks is really important. And I think we've got to be really cautious not to recreate things in hospital systems. Yeah. When they actually exist in the community, as Catherine was saying, we want to strengthen those. And we also want to strengthen them for equity because it's much more accessible, it's much more equitable for people to actually go into the community and source their health professional, but also their social prescriber, as Herbie said, their social worker, issues with gambling and finance. It's a much broader issue. Absolutely. And so I think we have to be cautioned about saying, there's not enough in hospitals, build more in hospitals. I, as a community person who's very interested in equity and health outcomes and access and sustainability of the system, say we should be building that outside, but we should be building the confidence of the system inside as a hospital system to know it's being delivered appropriately outside.
Yeah, great. Thanks, Inez. And I think it's a beautiful segue to go to Lisa Taylor on this. And I can see you nodding vigorously as Inez was speaking, Lisa. You've worked in the cancer arena for many years and currently at Peninsula Health. And your main role is clinical assessment, management and coordination of patients undergoing treatment within the chemotherapy day unit and the outpatient clinic. You also oversee the nurse practitioner-led model for SMICS, the System Urgent Review Clinic that Tennille mentioned earlier. Do SMICS provide more opportunities for patients to access supportive care? And are they routine, when services are offered at home, are they routinely given the supportive screening tool as part of that?
Yes. So yes to all of those things. And I mean, it has been fascinating to listen to everybody because having been in the acute setting for such a long time and obviously being on the morning to Peninsula where we do have some issues with access to some community supports, just through local councils and things, just because of COVID and shortages of staffing. I think the thing that's fascinating is, and listening to all the people who have actually told us about their cancer journey, we as nurses or health professionals think we can just fix everything. So all these people, and when we're talking about supportive care screening, even though it's from, originally came from the NCCN, you could use that screening tool on anybody who came into a hospital, but it sort of just fell into the cancer area. I think the issue is we do a lot of referrals through our symptom urgent review. So, and that's all the people who have told us about their cancer journey. We do as nurses, we give them information packs. A majority of people never look inside their pack. People have got to be ready to accept referrals. We can't force things onto people, even though we know, yes, it'd be great if everyone did cancer rehab, and it'd be great if everyone saw an exercise physiologist, and it'd be great if everyone saw a psychologist. People have got to be ready for that, and often they're navigating so many appointments and so many blood tests and so many treatments and radiation that it just doesn't come about. And I think what was interesting for me was through a little project we decided to tag on to our CERC just because we obviously don't have a survivorship person here. We did a little project with Peter Mack, but we did a little survivorship. We do a call through the CERC 4 weeks post-curative treatment. And we go through, you know, even though we've talked about the Cancer Council and they know about everything that we've spoken about the whole time, we go back about like cancer rehab, we talk about your GP, and we talk about, you know, chronic disease management plans. And like, I think for us, we do have a good understanding that the community does a good job at doing all those things. And we do know often in the acute hospital, we are stretched, you know, because when we did that recent, you know, for the Cancer Council, that survey for the Access program, even myself, I was quite shocked at the limited amount of EFTs for my allied health within my organisation. I knew there weren't a lot, but I was actually quite shocked when I saw it. But, you know, we talk about, and we send out an information pack about living well after they're finished their treatment, because sometimes after, even though we've got a strange relationship, when they've been coming to us all the time, we're kind of like their friends, but then they leave and they don't see anyone for a while and they feel like, oh, geez, I've just been dropped. So a lot of times I've found a lot of people have picked up referrals that, even though we spoke about, you know, look, we'd feel better, and we talked about, you know, chronic disease management plans, we talked about rehab, and they just weren't ready for it or didn't have time. But I've noticed a lot of people have taken them up in that, after that 4-week period where I've called to say, you know, how are your symptoms? You're still having any issues? Yes, that might continue. And then I said, oh, remember, and then we, you know, we make sure we say, oh, you remember you can go to the holiday program and stuff. So I think in referrals, I've noticed the biggest thing is that even though we talk about things, sometimes if we leave it up to the person, obviously we've got a much older population down here, they just don't do it. Yeah. So often for me, just quickly jumping online and sending a quick referral through is better. And we do a lot of my aged care. The majority of people, I'm quite surprised that don't even know about my aged care and don't even have a number. So yeah, I think it's been quite a useful little project. So yes, I think it's just, I guess my take home point for, you know, we've got to remember we've got the WeCan.org website, which is very good. I often put people onto that. There's lots of videos there. There is an electronic supportive care screening tool people can do even if they don't have access to someone. And, you know, I do use the Cancer Mind a lot, and obviously the Cancer Council, you know, the online form. So we just do a lot of referrals, but I'm in the mindset that I try and get them out to the community. And now that we've got home-based cancer care, there's some money in some allied health through, you know, through the department. So, yeah, I just think we, it's an interesting thing. None of us are perfect, but I think we're all doing the best we can with what we've got. And people have got to be ready. I mean, I know I've seen people, I've spoken to them about Power Care 10 times. Yeah. And, you know, and then eventually when we have another conversation, they're like, maybe I should do that. I'm like, okay.
It all comes down to the right conversation at the right time, doesn't it? And tools.
And it'll be interesting to hear about the project that's been done about the screening tools.
Yeah, that's coming up just really soon. Thanks so much, Lisa, for that insight. I'm going to go to Andrew Smith, who we haven't spoken to yet. And Andrew is an occupational therapist in the cancer sector. Worked in some of the country's leading cancer organisations, the Peter MacCallum's Cancer Centre, the Australian Cancer Survivorship Centre, Olivia Newton-John Cancer Wellness Centre, the Leukaemia Foundation of Australia, and is currently, very newly, with the Breast Cancer Network Australia. Andrew, we heard earlier that, you know, our hospitals, the resourcing can make it really hard to meet identified need. What services are out there in offering supportive care, and what sort of services are on offer? What can you fill us in with?
Thanks, Tracy. Yeah, and thanks for the introduction and great discussion had by all so far. I suppose before I answer that, I just wanted to pick up on a couple of things that almost all the panel members have sort of touched on, and I suppose it really comes down to how, as a sector, are we stratifying the needs of our consumers at different points along the cancer experience. And I sometimes think that we have sometimes by necessity, like a two-speed approach that a consumer or their family need everything or they need nothing. And there's a really enormous population in the middle that needs help with supported self-management, and that's sort of written along, all the survivorship models of care as a core part, along with the optimal care pathways. So in short, I think back to my time in starting in the sector 20 years ago and what was available then as far as supportive care in the community and what there is now. The short answer is there's lots. There's a lot out there. Services might be tailored around a specific tumour stream. They might be tailored around a demographic population, whether it's an organisation like Counterpart in Victoria who support women specifically, or it might be Canteen who support young people who've been directly affected by cancer, or their parents have been directly affected by cancer, or an organisation like mine who is specific to breast cancer. So long story short, there's lots out there. I think it was Lisa mentioned the WeCan website. If that's sort of one takeaway for all the audience members, if you're not sure what your the consumer that's sitting in front of you in a clinic is, could be connected with, jump on that website, and that will give you a good idea about what's available.
Yeah, great. In terms of how well utilised are they? I'm making a presumption about what your answer is, but what do you feel about how well we use them?
Yeah, tricky question. I think on the whole, probably not enough, and I think most of the panelists would certainly agree. I think it's better in some specific areas of cancer care than others, in some specific tumour streams or age demographics more than others. But I certainly think, and I know speaking to a lot of colleagues over the last couple of years, particularly in Victoria, it was so difficult for clinicians in the acute sector just to be, doing as much as they can to hold the system up. That supportive care numbers and referrals certainly dropped off in a lot of those organisations.
Yeah. Thanks, Andrew. So we've got one more person to put in the spotlight, and then I'd like to come back to and ask a question of Inez before we have a brief break and look at some of the questions and Kirby's project. And the last person being in the spotlight is Leanne, and it's your particular speciality has come up a number of times already today, Leanne. You're a palliative care nurse consultant at Alfred Health. Mm-hmm. And on the Alfred Health website, it states, only a small proportion of patients need to be seen by a palliative care medical specialist, and patients may also benefit from the nursing, social, psychological support provided by a community palliative care nursing service. So we hear more and more about the benefits of early referral to palliative care. It's been mentioned a number of times today, but we know that current resources can't support the blanket referrals. How do we prioritise patients, and when is the ideal time for a referral?
Yeah, thanks, Tracy. I think like everything else, and I think particularly like Viv described it so beautifully, is early referral. We need to make sure it's at the right time for the right person, and everyone is very different. Sometimes I think there's a push that if someone's diagnosed with a metastatic disease, we need to do a palliative care referral. That's not the case. I think the most important thing is that we need to have, or clinicians of, every discipline need to be comfortable to have a discussion with someone about palliative care. We all need to be familiar with what palliative care is, that it's not just end of life, that it's about symptom management. And also that the discussion doesn't have to be within the hospital. It can be with the GP, as Inna said, who has known the patient for so long, and they can help have those discussions and clarify the need for it. It has to be done at the right time, and resources are really stretched. At the moment, we've got some patients here that we're trying to get some community support for through community palliative care services, and there's 2 or 3 week wait even for them to get a phone call from that community service. So it's also a matter of looking at what other services are available and what do they need. Is it back to the CERT clinic, and can we then help the CERT clinic provide some information or to help them with symptom management? Is it to the cancer helpline to talk through, some of the psychological issues that they may be facing? So I think we have to be aware that the resources are really tight, and I think a person who has a cancer diagnosis, who has a trusted relationship with a clinician, that probably is a perfect person to start having the conversations about palliative care, but also for clinicians not to be quite happy to reach out and ask, is this someone that your palliative care service could help? And we do a lot of our work with clinicians, with GPs, to say, we think a community pal care referral would be really beneficial for that person, or not at this point. These are some of the other things that you could do to help them. So it's similar to a lot of the themes that have been brought up. It's the right time for the right patient.
Yeah, great. And Leanne, people knowing, that inside of palliative care isn't associated just with dying, that it's actually that qualitative of life, and how do we all in the system, but as users and as healthcare professionals, actually know that and change our thinking around that. So fantastic. Thanks so much, Leanne. Just one quick one. If you could just can you give us an example? And I know you did one in just before, but what's an example of how a palliative care service helps patients and their families, increase their quality of care? Have you got just a little thing you can share with us?
Yep. We will often see patients that will come into hospital that will be in a pain crisis. It may be because of progression of disease. It may be treatment related. So they may be having active treatment. We can help as a consult service here to provide some expert information and resources to try and help manage those symptoms. They then will be discharged home. We can link in with a community palliative care service that can follow up with helping with the symptom management, and also helping with conversations about advanced care planning, goals of care, would they want to come back to hospital, those sorts of things. And also at the Alfred, we're extremely lucky to have a outreach service as well. So if a community service can't get in to see someone who we're wanting them to see for symptom management, our outreach nurse can bridge that gap and then work seamlessly and transition that person to the community palliative care service.
Okay, great. Thank you. Thanks, Leanne. And it leads me to the last question before we have a stretch break, and then we'll come back for a couple of good, juicy questions and Kirby's overview. But Dr. Inez Rio, just a thought from you, and it really leads from what Leanne was just saying around the supportive care actually being coordinated in the community for patients. What capacity is there out there, do you think, to be able to do this work, for it to be coordinated in the community?
I think this is core work for general practice. It's a core, a patient-centred medical home that's sort of centred around general practice is what we as general practitioners actually believe in, that concept of, longitudinal, holistic, family-based community care. And this is the epitome of something like this. But I'd be wrong to say that we don't require more support in general practice to do that. And that support is about, communication and collaboration with hospital services, so that we know what's happening, but we're actually part of the discussion within them, that wraps around those services, so that we know what's been identified in the hospital as perhaps requiring supportive needs. We understand what, specialist services are available. We have a quick referral mechanism back into hospitals when that's required, especially for survivorship care, things like, bone care, reproductive care, menopausal services after cancer. There's a whole lot of things that people require over their cancer journey and during their life. And we need the hospital specialist services that have that to actually, be able to have quick access back into the patient.
Yes.
And the other thing that we need, I think, is sort of secondary referral pathways. In other words, advice to us to actually assist our person, you know, the care of our person in place when we need to. So when we have, you know, issues with, you know, the person's got a rash, you know, what do you think? Could it be the medication? Can I get the dermatologist to have a look at it over FaceTime? I mean, these things are absolutely possible, but we don't have a funding system and we don't have an accountability or a communication system that treats us as a whole across sort of, you know, hospital services, public, private, and then sort of community health services, and then on top of that, social services, I think.
Yeah. Thanks, Inez. Great overview. And Debbie's popped in the chat just that she also found it extremely difficult to find exercise programs after chemo and then after active treatment. So that perspective of just even being able to get access to programs being in place and being able to access them. Folks, thank you. What we are going to do, that incredibly interesting conversation is, we're all going to have a stretch for starters. So what I'm going to do is I'm going to put up the holding screen, folks that are watching with us, but don't go away, because first off, what I am going to do is I am going to launch a feedback poll, because we would really like to know how valuable you're finding this conversation currently. And there's more to come, we know, but it's really useful for us to know, are we on the road for the majority of you? I'm sure it won't fit the purpose for everyone, but that would be great. And when we come back, we're just everyone's going to pop off their cameras, and in 5 minutes time, so just after 1:30, so 1:32, we'll come back on and we'll have a look at couple of questions and the project that we were talking about earlier. So look forward to seeing you all soon. And welcome back, everyone. Got our panelists coming back on. If you got to go and do a bit of a stretch and a bit of a jig after sitting for a long time. Thanks, everyone, and thank you so much to everyone who is still with us, which we've got most people still with us, which is absolutely fantastic. In fact, everyone, which is sensational. Just goes to show, and the poll absolutely showed that a big majority of people are finding this very valuable, incredibly valuable, or highly valuable, and really want to know more. We're going to give you a QR code at the end of this website. I will just share it for a moment now, just in case you want to take a screenshot or grab your phone and pop it up. And what that QR code will take you to is a form where you can put your details in, and we can make sure that the SMICS, beautiful SMICS crew, the team that have put this together, done an amazing job, can get in touch with you and we can keep the conversation going. So please pop your details in there if you wish, and I will put that up again at the end of the session today. Kirby, I am going to ask you if you wouldn't mind sharing this project with us that you were talking about earlier, and taking it through. So I might throw over to you if you're happy to go. And you'll just need to come off mute.
Thank you. There we go. It's just finding that button. It always disappears on you.
Yeah, it does, doesn't
it? So look, thanks for the opportunity to present on this project. And I think a lot of what we've already been talking today highlights the need to do things a little bit differently, perhaps, and that it's definitely not a one-size-fits-all. So I think multiple approaches to this are really worthwhile. I might start with a bugbear of mine, which is that we get these very excitable people in technology who create solutions for a problem that they manufacture or that they think is out there. And we get them thrown at us all the time. One of the good things about this project is that it started with a problem statement, and we workshopped what we could possibly do to resolve it. And that problem statement really was, as we've already heard today, that these screening tools were being completed on a select number of patients, typically those in our day infusion centres. They were then filed in the medical record dutifully and not really acted upon. The other issue that was brought to us was that the treating physicians, consultants, really had no visibility of the results or outcomes. So I think we can all agree that that's a fairly common problem statement. And really, so our solution was to try a different method of delivery. So this project was not about testing the supportive care screen tool or the validity of that, although we did add some additional things around physical activity, noting that that was sort of an area that was missing from our perspective. But really what we wanted to see was improvement in completion rates, improvement in access. So a lot more treatment for cancer is now provided in the home using oral medications and all other sorts of different modalities, not just in day infusion centres. We wanted to improve the outcomes. So, and by that, we really meant the responsiveness, what we could do about the outcomes identified by our patients, and improve the visibility of the results. And lastly, I'll just throw a big shout out to SMICS, who supported us with funding to undertake this project. The biggest and most important thing that we did in this project was really the planning piece. What we wanted to be able to do was develop a protocol that others could utilise that really showed how we could get patients to engage with an electronic supportive screening tool. It took a lot of stakeholder engagement across patients, doctors, nurses, allied health, administrators, etc., to really work out how we could go about this. We undertook some serious process mapping. We did some great user testing, and we have now finally drafted a protocol, which we're in the process of testing. When we looked at it through all of the planning, we had a captive audience group, and we had a out in the wild group, as we kind of ended up considering it. We had patients who were coming into our hospital for their chemotherapy or day infusion, and we had patients coming in here as well for their radiation treatment. Then we had this other nebulous group who had surgery first, or were being treated in the home, never admitted and never really hitting a Cabrini patient administration system. So captive audience, theoretically, we should be able to engage that captive audience pretty well. The surgical and non-admitted patient group, much harder. So we decided, and I like it, Tracy, that you just put up a QR because it just shows how far we've evolved as a result of COVID. We devised a QR-based system for self-enrolment. And we wanted to test this to see if we just put the information there for patients, accessible information, would they actually take the initiative to enrol in something like this? Is this important to them? It might not be important the first time they see this sign, but maybe it's the third time when they're feeling a bit unwell or feeling a bit overwhelmed that they go, actually, well, yeah, I do need a bit of support, and it looks like this is how I could go about getting that. The workflow that we designed was really around, ideally, we wanted to introduce patients to this early. We wanted to try and capture that sort of awareness of these other resources and services that were available not long after diagnosis. And we did, as I mentioned, we went for that self-registration approach. Once a patient did self-register, it was very simple. Our admin confirmed the patient and a pathway was assigned. And by that, I mean patients were put on the supportive care screening tool pathway. But we could also assign other pathways later and collect this full sort of patient outcome picture. So if you're a breast cancer patient and you were participating in our rehab program, you might have another tool like the FACT-B, a particular tool for breast cancer patients, and we could see that whole data set. We set the frequency as 3 weekly, and that was after testing it with some of our patients and also seeking feedback from our clinicians. And we were doing it in 3-month blocks. So we wanted to provide patients with the opportunity to essentially opt out, but we decided to opt back in. And during that time, every time they completed a tool, we're lucky enough to have wellness coordinators, so they would review the outcomes. They were able to provide follow-up phone calls, arrange appointments if that was what was required, or address it on the phone call. And as I said, patients could opt back in. The results shared with the treating doctor, and really we didn't want to overwhelm our doctors, so that was really more where we had an aberrant result or something that was of note. Otherwise, and coming soon, it's going to be put within our medical record on the patient administration system. I'm going to stop talking for a moment and just give you a bit of a snapshot. It's about 2 minutes of the software that we use called eCaptus, developed by Medicity. This isn't specific to the cancer, the supportive care screening tool, but just to give you a quick sense of how we were doing it.
Introducing eCaptus, a secure medical-grade cloud-based software tool that has been designed specifically to capture and report patient-reported outcome measures, PROMs, simply and seamlessly. PROMs enable patients to provide direct, timely feedback about their health-related outcomes and experiences. When tailored and integrated with health programs, PROMs have been shown to drive improvement in clinical outcomes while meeting the expectations and needs of people accessing care in today's informed society. Healthcare providers using eCaptus administer their own health-based questionnaires relating to quality of life, symptoms, functional ability, and other aspects of patients' health and well-being. They start by creating or importing patient records and assigning PROMs to patients based on their condition or care path. eCaptus then automatically schedules and delivers an SMS or email containing the hyperlink to the PROMs assigned to that patient. The patient completes the questionnaire using their own device. No apps, no setup required. The data is instantly accessible to the care team through the eCaptus portal. Responses that are outside of predefined thresholds trigger alerts to the care team, who can then intervene if required. eCaptus incorporates the following additional tools and features: a custom questionnaire building tool which allows total freedom to define as many different programs as needed, a clear dashboard reporting tool that provides simultaneous views of cohorts of patients being managed, longitudinal patient records highlighting changes over time and allowing optimisation of the care delivered or the process by which it is delivered, open API or integration to other clinical systems, including electronic medical records, GP and primary care software platforms and research databases. With a rich feature set, eCaptus is suitable for many common use cases, including healthcare registries, telehealth programs, clinical research studies, and early discharge programs. For more information, please reach out at hello@medicity.com.au or visit us at medicity.com.au.
So that just gives you a sense of the tool that we were using, and we were able to work with Medicity on developing this. Now, I used myself as an example case to get these screenshots recently to show you, essentially, we've designed the system to suit our needs. We've tailored the SMS that patients receive initially. We've given them some narrative around why we're asking them to complete this and what to do in an emergency. This was really addressing user feedback and stakeholder feedback around, well, what if a patient puts in a 10 out of 10 distress thermometer and expect you to contact them within 5 minutes to address that? We didn't want that sense, so we've provided in those things. And at the end of it all, we've also put in some outcomes for the patient. So if this patient, I identified some quality of life risks, and we've also got some resources available to the patient that they can click on immediately, but they also know that we will follow them up. And we also give them that advice in high risk areas to contact their treating team. That then, as it showed, pulls straight into the dashboard, and we can see each of the PROM scores, those patient-reported outcome measure scores. And although it looks like I've got a lot of PROMs, it's delivered seamlessly. So the questions just follow in that sequential order, and we can see the results there. I'm colourblind, so I'm not going to tell you which results are out of sync here. But for those who aren't colourblind, we'll be able to see that different results come in as red. Speaking of enablers, really, our wellness coordinators were the biggest enabler for this to work, and other organisations have similar positions with different titles, but someone to be responsive to the results and to follow up with a grounding in supportive care and cancer care to be able to address those questions and concerns, but also provide care coordination and follow up and appointment arrangement. We have a group of engaged clinicians, and those clinicians are the ones whose patients have enrolled and self-selected. And we also have an exercise and wellness centre that can provide all of these services listed here. And a lot of that is provided under private health insurance funding. So I guess an enabler, which we've all discussed already today, is having some funding mechanism. But we are commonly finding that we're linking back with general practice. advising patients to engage. And it's great to have Inez on here and hearing the comprehensive nature of care that she provides, linking back with GPs to undertake some of that care, chronic disease management planning to help our patients. So far, this is what you all really want to hear is how's it gone? What are the outcomes? So we've developed a protocol which we think is reasonably good. Within the first month, we had more than 40 patients self-register. And pleasingly, they weren't all from one tumour stream. So we saw every tumour stream represented within those 40 patients. My conclusion, however, was that the self-registration was not working adequately. That was capturing a blip on the radar with regards to the number of patients we see here at Cabrini. And I hate the term, but we decided we had to pivot. And so we recognise now that different patients will engage in different ways, and the QR code accessibility may not be the only thing. I was going to trick patients and have it as a COVID check-in system, but that was thought to be a little out of sorts by our ethics team. So yes, we're going to keep the QR code there. We think that's important. We're also moving to a registration form base for every new patient who comes into the system, be that through our medical officers' rooms and also in our day infusion and radiation space. And it will look like part of routine registration, which we all know that supportive care screening is part of routine care. We're also looking at IT integration, which the video showed, where any new patient identified would get an invitation to participate in electronic supportive care screening tool if we have their email address or mobile phone number. So that is all I wanted to present from a PowerPoint perspective. We think this has legs, so to speak, and we think it's a great addition. The one concern that we have is the sterile nature of any patient-reported outcome measure that is delivered via an electronic mechanism, and the very personal nature that we've all been discussing today of supportive care screening. And we've been working with our day infusion unit to really ensure that they have access to these results. And the ideal scenario in our mind is that these results are accessible to the healthcare team. So as when the patient is visiting for their chemotherapy or their radiation therapy, the nurse who they've developed a good relationship, the doctor, the physio, whoever, can say, oh, I notice you have completed your survey. That's really great. You've expressed some distress in there. I know the wellness coordinator has probably followed up with you, but is there anything additional that you'd like to talk about or other resources? It's just that more holistic and team-based approach. Now, I know we've got a bunch of realists and I'm probably erring towards the optimist side of things, but that is our aspiration and that's what I'm going to continue to work towards in this space.
Kirby, in terms of uptake with people with no mobile phones or limited English, what's the thinking around that?
So the no mobile phone, we can deliver it via email and then it can be completed on a computer. We are looking at how clinicians, so you might have noticed on the edge, there was a weird acronym there, CROM, which is Clinician Reported Outcome Measure. And so for our non-English speaking, eventually translation will be a thing for us for the tool, but that's not quite there. So for the time being, it's really going to be about clinicians entering that information as they have been on paper, but directly into the database. Right. So it still enables all of the same outcomes in terms of our wellness coordinator follow-up and the like, but it's actually supported by the clinician doing it with the patient. Again, that works well for our captive audience. We still have not quite solved the problem, and I will call it a problem, of those out in the wild who are probably less supported because they're being managed through oral chemo and those sorts of things.
Yeah. Thanks. Fantastic initiative, and I can see people getting very excited on the panel around it. Does it, over your 40 patients, was it across the different parts of a cancer journey from, the early right through to the more advanced space?
Yeah, it was. We had some patients very early. We had a patient on day of diagnosis who enrolled, through to patients who were actually just following up, sort of routine care, some 12, 18 months after, but we're still interested in, and I think it was Debbie who mentioned those sorts of things that prop up around family supports and other things that might come up later, being able to still link in somehow into that service and not feeling like you've forgotten. So yeah, we have had people across that, and as I mentioned, across the tumour streams as well.
Yeah, great. Beautiful. Now, I would like us to answer a couple of the questions that have come in. There's also going to be follow-up questions. Some have been answered already. But I would like to just ask the panel, does anyone have a burning question of Kirby that you think would really be useful for everyone on this webinar to hear that question as well, rather than you ask it of Kirby later? Tennille, you've popped us
me.
Yes.
Yep.
Pick me.
me. Kirby, I'm so excited about your project. It is actually in line exactly with what I'm doing with my PhD for supportive care delivery for upper GI cancer patients. I'm lucky enough that we are actually capturing our patients to self-report their PROMs through the cancer registries. So for me, I'm working with the Upper GI Cancer Registry. I was just wondering if there's been any discussion about, because that way we're actually getting all our patients. They're not just the captive, but also, as you call them, out in the wild. Just wondering if that has been something that you've thought about, how to maybe work with the cancer registries to onboard and recruit patients into the trial or the study.
Yeah, it's a great question. My long-term goal is that this will become part of that process when you are put onto a registry, that this, is the ubiquitous approach for all services. And one thing we've included in there at the moment is treatment modality. So where are you? Are you having chemo? Are you having radiation? Or are you, out in the wild? You could link in with a service through that treatment modality, which would help direct the follow-up. So we're aware that some of the registries are a little tricky to integrate with, and that's probably the big thing. So we're testing that locally with integration first, but it's certainly on our roadmap. I didn't want to quite go there until we had the confidence we could follow up on any results that needed following up and manage so that local cohort first. But Tennille, I think you and I will probably have a catch up fairly soon to explore some
I think this is a really exciting opportunity.
Beautiful. And I'm sure there's people out in our audience also going to get in touch with you, Kirby. And I just want to bring people's attention to something in the chat, which is a link to the Grampians Integrated Cancer Service, who are doing a patient-reported outcomes measures living up to the promise of better care, being held on the 9th of November. So there's a link there to their ticketing as well there. Inez.
Oh, look, fantastic stuff, Kirby. I was just going to ask a very brief question, just that it would be really beneficial to go up to my health record, both from a GP access point of view, but also from a patient access point of view. I was wondering about whether that was happening.
Yeah, it's a great idea. What we don't want to do, given the frequency of the survey, and some patients already have completed 7 or 8 surveys, is overwhelm my health record with individual surveys. So you can't find the information you actually need. We're working with Medicity at the moment to get sort of high-level reports or the important reports that could go through and be filed into my health record, or firstly for us into PAS. I think that's a great idea though, Inez. Yeah, thank you.
Okay, beautiful. I'm going to leave that. That feels like something where people want to pop their names into that QR code so they can stay in touch. Absolutely. It feels like it's got a lot of power, a lot of energy to it. And I just want to put out, I would really like to just get some thoughts from the panel around this. There's been a whole lot of great questions. Some of them have been answered. There's some that are quite specific. So there's been a couple specifically to you, Catherine, around Cancer Care Victoria, your directory, but also how you've the capability building you've done, which I might see if you can have a look at and give an answer to. But this one around measurement. And the question is, are there alternative supportive care improvement measurements that could be collected to help with building business cases to get supportive care prioritised by administrators? And the person has written, distress thermometers and nutrition risk screening often provide early identification of unmet allied health needs or a flag for functional decline. If these needs go unmet, then it's likely to impact other metrics, such as length of stay, of course, and preventable hospital admissions. So the original question, are there some alternative support care improvement measures that could help that business case for further funding, further bringing supportive care into the core work of a cancer journey? Who's going to be off mute to give an answer to that? Is it the $1 million question?
I'm happy to start us off, Tracy.
Thanks, Danielle.
I think we've spoken a little bit about this. A few of the members on the panel have spoken a little bit about this throughout. But I think number one is looking at referrals and action items from those referrals. Lisa was speaking earlier. We can't force patients to uptake referrals, but we can certainly look at them in terms of the number of referrals made directly from supportive care needs identified. We can also look at the uptake percentage of those referrals in terms of the patient actioning that referral and having an appointment. We can also look at emergency admissions, spontaneous admission, unexpected admission rates to hospitals. They're the four big ones that kind of spring off my mind to help build that business case straight up.
Beautiful. Thanks, Tennille. And I know that some of you have probably got a hard at 2. Andrew, I know you do, Andrew Hayden. Any thoughts from you? I know that you sit in this space of measurement a lot. Any thoughts that you can give us around this?
Look, it's really, I think it's really difficult. I don't know that there's easy, measurable, factors that we can use. I mean, Tennille's raised some very good points, and it's stuff that we've been struggling with for a long time. So I don't actually have a good, simple answer that we would have done it by now if we knew the answer that would actually generate a change in the attitude of the administrators.
Yeah. No, thanks, Andrew. I think that reality is pretty important. So Inez and Leanne, I'll finish up with you. Inez?
So just quickly, look, avoidable hospital admissions and presentations are very costly items, and it's interesting. I mean, there's no doubt that we could measure, in a well-funded study, I think, an intervention arm that actually had people with, early supportive identification of needs,
yes.
Referral back and a systems-wide approach, which is, I think, what we need, a system-wide approach across hospital, general practice, peak bodies, sort of segments, and those that didn't get it, and what the cost of their journey in healthcare dollars was over a few years.
Yeah, fantastic. Great. Beautiful. Via Leanne, I might just pop by Ellen, because I think you were going to say something to Ellen. So I'm going to go to Ellen and then Leanne.
So I think on top of that, length of stay is also what our administrators look to. And I know when I looked at this at another organisation, it was around the total demand, in particular in our dietetic and social work service, which meant that we were pulling from the inpatient unit because patients needed to get home within that 8-hour time frame, which meant that it was delaying discharges, which was holding up bed flow, and that was another piece that we were able to put in the business case.
Yeah, great. Thank you. And Leanne?
Yeah, just really quickly, one of the things that we looked at, there was a lot of frustration about people not wanting to do the screening because we didn't have anyone to refer to when we needed, and we were really encouraged to continue to do the referrals, because then if allied health could not respond to them, then it was showing that there was a need to increase those resources. So as frustrating as it was to say, keep doing the screening, keep doing the referrals, was also a way of identifying the gaps.
Fantastic. It feels like a great research project on the boil, ready to go, doesn't it? And I just love the pull, Inez, that you've given us also around the connected up and the system-wide thinking about the whole of the journey rather than via health service measurement. So how do we lift up above that to a whole system approach? Can I just say thank you so much to all of you as a panel. It's been just an absolutely inspiring and interesting conversation to have. Thank you especially to Debbie and Viv for bringing their particular personal journey to us. I think your voices are so important to hear, and we probably could have spent a whole 2 hours just listening and diving into you. We know that, and maybe another opportunity to come down along as well. But thanks so much for being here. Thanks everyone for giving their time. I am going to share that QR code again if you are interested in being still part of this conversation and taking more time to think about this and to come together as a really strong collective around it. It's been great comments put in around people's perspective around how we could address things such as the psychological issues, not having the amount of people that we need to service those. It's been great impact on in the chat also on people from their experience around the screening tool, which is all going to really help the people working at this to improve supportive care across the whole state. But certainly thank you so much to all the people that come from the South Melbourne area of the Integrated Cancer Service, and are linked into there, but we've also had great expertise from a whole of system approach too. So thank you all so much for being here today, and we'll see you all again, and please stay in touch so that we can keep this work moving. So thanks very much, folks, for your time.